So hi guys, welcome back to my channel. So in today's video I will be talking about WHO labor care guide. In last video I have taught you about partograph and now LCG. So these two things are very important. It will be there in your viva, in your practical exam. You cannot escape it, The charts will be given to you, the graph will be given to you, and you have to explain what is there. You have to interpret. So this is very important topic. You need to know it both for your practical and theory exam, and this is important for all of us, be if you are an MBBS student or a resident, PG resident and doing MSMD, DNB, whatever. If you are a practitioner involved in ops care of the patient, in you are conducting normal vaginal delivery, so we all should be knowing it. And also for the nursing students and the nursing officers working in the labor ward, we should be knowing this topic. So let's begin. So welcome back to my channel, Dr. Z, the AIIMSified WombWhisper. My references are WHO Recommendations on Intrapartum Care 2018 and WHO Labor Care Guide Manual 2020. So what is the rationale behind WHO Labor Care Guide? Why not partograph now but labor care guide? So what are the changes? Most of the complications like 1/4 of neonatal death and 1/3 of maternal death and half of stillbirth occurs during childbirth and labor. So to reduce these complications, we need to improve the quality of care we are providing to our patients during childbirth and labor. And this is the most impactful strategy. If we are putting any antenatal or postnatal strategy, that is not as helpful as we are revising our strategies or being more careful during this intrapartum time. So for this, WHO labor care guide has come, and it has incorporated many changes as compared to modified WHO partograph, which we'll be seeing now. If this topic comes as your theory question, and even in your practical viva exam, examiners may ask you about advantages of labor care guide, similarities of labor care guide with WHO modified partograph, dissimilarities also. So you should be knowing it. So what are the similarities? Both are graphical presentation of progress of labor against time, as you will see, and recording of important clinical parameters for mother and the baby for their well-being. And what are the differences? This is very important part. In partograph, as I have taught you, active phase begins at 4 cm. Here in LCG, I'll be talking labor care guide as, I'll be calling it as LCG. It begins at 5 cm. In partograph, we use a fixed rate of at least 1 cm per hour for action, and in labor care guide we use evidence based time limit. It's not like from 5 to 6 cm. To go from 5 to 6, there should be not more than 1 hour. It's not like that. For each centimeter dilatation after 5 cm in LCG, some evidence based time limits have been given. Okay, so it's not like modified WHO partograph where there has been a fixed rate of dilatation for each centimeter of progression. In partograph, there is no section for second stage monitoring, but it is there in LCG. Also in partograph there is no supportive care, but it's there in LCG. In uterine contractions, in both the places there are place for uterine contractions, but you will see afterwards that in partograph we can record the strength as like this. If it is mild, we record like this. If it is moderate, we do like this. If it is good contraction, we just put the block as solid. But it's not like that in LCG. There is no provision for strength of contraction, only duration and frequency is there. And response to deviation, there is no mandatory response, but in LCG there is an alert column where where we match our assessment with that of alert column, and according to that we take the response, we give the response. Okay, what are the advantages? So most are as like the partograph, monitoring of maternal and fetal well-being. This is different from partograph. We provide supportive care to ensure that the women is having positive childbirth experience. And if there is any complications, we just identify it early from the graph and specific action is taken. If there is any abnormal finding, we prevent unnecessary interventions in labor by following the evidence based recommendations, and it supports audit and quality improvement of labor management. So what are the aims of labor care guide? Monitoring and documentation of progress of labor, to guide skilled health workers to provide supportive care, assist skilled health professionals to manage emergencies. It is same as like that, to prevent unnecessary use of intervention, and to aid audit and quality enhancement of labor management. So for which patients we should be using labor care guide? We use it for all patients in labor after 5 centimeter of dilatation. Okay, and for high risk patient we need additional care, otherwise for low risk this labor care guide is enough. When will you initiate labor care guide? Obviously at or after 5 centimeter of dilatation in the active first stage of labor. And where it should be used? It should be used in all levels of healthcare, be it primary, be it secondary or tertiary care hospital. And what is in which level it is most beneficial? In primary health centers, because you can early identify the complication and refer the patient timely for prompt management. And who are our targets audience? Whoever is involved in managing the laboring patient, be it obstetricians, medical practitioners, nurses, midwives, all of them. And how do we use the LCG? We assess the findings and then we record it on the LCG paper, and then we check it against the alert column, and then we plan our management. Okay, if any deviation is there from the expected findings, then we take a decision to intervene in the course of labor. So what is the structure of LCG? It is comprises of 7 sections. Each sections I'll be talking in details with you. So in the first section there are patient details. Okay, and there is the time axis. So similarly as it was in partograph, there is time and hour axis. So you plot the actual time when you begin plotting the LCG, what was the time, 6:30 AM, PM, whatever, and then in hour as it was there, first hour, second hour. And as you can see, here are 2 sections. This is for first stage of labor after 5 centimeter dilatation, and this is for the second stage of labor. As you can see, only 12 hours time limit is given here, but if labor exceeds that, you can use the second graph paper. It's not like after 12 hours we cannot allow patient for further progression. You can allow, you just use the second form. And in the second second stage of labor, you can see there are 3 hours given, only 1 to 3. Okay, so in section 1 there are patient details like this. There is name, so you write the full name of the patient, and against that all the details has been given. This I have just put for your reading. So this is the gist. Name is given, then you write about the parity. You ask the patient history and see the medical records and just write the parity. Labor onset, if it was spontaneous or induced, or spontaneous or induced, you just mention it. Active labor diagnosis, at what date it was diagnosed. Ruptured membrane status, at what date and time membrane rupture was there. And risk factors, if any pregnancy related complications or any previous medical comorbidities is there which is risk factor for this patient, you just mention it. So this is the first section, and after that you can see there are other sections, second, third up to 7, and there is an alert column against each sections. Alert column, we record our findings here in blocks, and we match our findings with that of the alert column. If anything matches the alert column, we will mark it red, we will circle it red, and that is an alerting thing for us then we should be intervening. We should take the action. Okay, what needs to be changed for the next hour or so. So this is how we plotting. So example is, suppose this is Mrs. X. She is para 2. Labor was spontaneous in onset on 6th of July 2025. Date of active labor, and then membrane rupture was at 5 a.m. and the risk factor is history of stillbirth and anemia. Okay, so these things can complicate labor and the outcome of labor, so you mention it here. Now the second section is about supportive care. This is the very essence of labor care guide, giving patient positive childbirth experience, and we record it every hour. So after you have filled this first section, now comes the second section, which is supportive care. Here what things are there? Companion, pain relief, oral fluids and posture. Okay, so you should be knowing the abbreviations. Like in companionship, either it is yes, no or women declines. So N is alerting. Either patient should be given companion, or if she does not want, then that is another thing. But denying companionship is alerting. We should not do that. If there is no companion, we circle it red, and then we should be providing her companion, family member, husband, whatsoever, as she will need support. Now pain relief, same, Y for yes, N for no, D for women declines. We should be giving patient pain relief, and if she does not want, that is another thing, but we should not be denying. Okay, so no is not an answer. So if no pain relief is given and patient is wants pain relief, we should be giving her. Again, oral fluid, most of the time patient don't understand if they should be taking something or not, and also doctors, nurses, they don't tell them clearly, but we should always be telling patient to take adequate fluid, semi-solid diet, liquid diet, whatever is allowed as per the status of the patient, but she should not be like taking nothing. Okay, she should be taking adequate fluids. Similarly, yes, no, patient decline. And posture is supine or mobile. So SP is supine, M is mobile. Patient should be mobile. She should not be lying in the bed whole time during the labor. Okay, so she should be mobile. That will help her in progression of labor. Okay, so you record it every hour. Now section 3 is care of the baby. So what things are there in care of the baby? It is baseline fetal heart rate decelerations, amniotic fluid, fetal position, caput succedaneum, molding. So alerting thing is when fetal heart rate is below 110 or it is more than 160 beats per minute. Deceleration can be early, late and variable. Late deceleration is bothersome. It is an alerting thing. Variable deceleration is okay, early deceleration is okay, not so alerting, but it should not be red. If it is late, you mark it red, you circle it red. Similarly, these two things you should be checking half hourly, every 30 minutes, baseline fetal heart rate and if there is any decels or not. Okay, so if there is no decel, you just write N, but if there is late decel, you write L and you mark it red because it is alerting. Okay, now amniotic fluid, if it is clear, if it is blood stained, if it is meconium stained. So meconium stained 3+ is alerting, and fetal position is P is occipito-posterior, T is occipito-transverse. So P and T, labor progressing, but there is no rotation of fetal head to occipito-anterior, that is alerting. So again you mark it red. Caput succedaneum 1+, 2+, 3+, molding 1+, 2+, 3+. I have told you about this in earlier videos, so go and watch my earlier videos also. So 3+ is alerting, and you should be checking these 4 parameters 4 hourly whenever you are doing per vaginum examination then. Okay, and you plot it every 4 hourly. You see the example in section 3. You can see baseline fetal heart rate and fetal decelerations, they are being plotted half hourly. and then the amniotic fluid fetal position caput molding has been plotted like this, and again they will be plotting after 4 hourly or whenever the per vaginum examination is being done. Now section 4 is about care of the women. So you check the fetal you check the pulse rate, you check the BP, systolic, diastolic, you check the temperature and urine for presence of any protein or acetone, which acetone indicates dehydration of the patient. So this is the alert column. Pulse rate less than 60, more than 120 is alerting. Systolic BP, if it is less than 80 or more than 140, it is alerting. Similarly, diastolic BP, temperature and urine protein and acetone. Now section 4 example, you see section 3 also these 4 things: amniotic fluid, fetal position, caput molding are being plotted 4 hourly. Similarly, care of women is also being plotted 4 hourly, and whatever matches with the alert column you just circle it red. So this is how you plot and this is how you should interpret. If like SP is written, what does it mean? Patient is supine, which is not good for the patient and the baby. So what will you do? You will tell the patient to be mobile, to walk, to do these exercises which are being told to do. So this is how you interpret, and you should check every section. What is wrong with this section? What you should be doing next? What does this P means? What if this P persists? Okay, so you should be knowing this. So this is just the example. How do you? And now section 5 is about labor progress. Okay, so this is also very important. You see, in labor progress there is contractions per 10 minutes, there is duration of contraction. So contraction less than 2, more than 5 is not good. It should be between 2 to 5, and duration should be between 20 to 60. It should not be less, then it won't help in progression, and it should not be more than for 60 seconds, otherwise it will lead to hyperstimulation, fetal distress and so and so. And you should be noting it half hourly. And if there is something wrong, if it is supposed for 10 seconds, you mark it red. If it is for 70 seconds, you mark it red. Now this is the change from Partograph, where there was a fixed rate of cervical dilatation, that is at least 1 centimeter per hour. But here, as you can see, from going from 5 to 6 centimeter, duration of 6 hours has been allotted. Okay, so if patient does not progress from 5 to 6 in 4 hours, that's okay, you can give her 2 more hours. Okay, similarly, to go from 6 to 7, 5 hour time has been there, 7 to 8, 3 hour, 8 to 9, 2.5 hour, 9 to 10, 2 hours. So all this time are given. So you see here, at this time in first hour when she was 5 centimeter, then after 4 hours she was checked and she was 8 centimeter. So that is normal progress. If she had been even 6 centimeter after 4 hours, that was normal only. But once she has been 8 centimeter, you see the time to go from 8 to 9 is allotted 2.5 hours. So you should not be checking after 4 hours. Okay, you should be checking within 2.5 hours also. So see, she has again been checked after 2 hours. Okay, and she has progressed from 8 to 10. So that is normal. Similarly here in descent, you see whenever you have done per vaginum examination, whenever you are checking the dilatation, you are plotting the descent of head, and the descent of head you are checking per abdomen. Okay, this is where confusion arises. This is where I also get confused. Sorry if I have ever taught you wrong about this, but it is checking descent of head per abdomen, in fifth. If it is 4/5 palpable, you write it as you just do it, make it round in 4. If it is 3/5 palpable, you mark it at 3. If it 2/5 palpable, you mark it at 2. So you plot it when you do plotting of cervical dilatation, at that time only. So here all the details are given. you know. Now come section 6, that is medications. So you do it hourly, you plot it hourly, whatever medication you are giving you just write it there. For oxytocin there is the section, so if you are giving oxytocin write yes, if it is yes then you write it at unit per liter and drops per minute. If you are not giving just write n. Okay, similarly if you are giving any other medication, insulin, magnesium sulfate, you just write the name, dose and route of administration. If not then n. Similarly for IV fluids, yes or no. Now section 7, this is very important section, shared decision making. So you have assessed if the progression is normal or it is alerting, and then you plan accordingly. If it is all fine, if it does not follow in the alert column, so you continue the routine monitoring. If you think something is wrong and you need to prescribe any diagnostic test, you do it. If you think contraction is not adequate, then you start oxytocin infusion. If you think there is fetal distress and you should do artificial rupture of membrane, you just write and do it. And if you think that second stage has gone beyond 3 hours, you just apply instruments if the criteria are met. And if the criteria are not met, and if at whatever time there is something which is very alerting and conservative measures are done but still the things have not settled, then you take for cesarean section. So whatever plan you make, you just write it there and take into consideration that women should be involved in discussion. It is not like that you and your colleague are just talking among yourself and you just made the plan. You should tell the patient that this is going wrong, this we are going to do this, we are putting you in left lateral, we will start IV fluids, but even after doing that things are not settled, so we are going to do cesarean section so that it is safe both for your baby and you. Okay, so you should involve the patient in discussion and you should allow her. It's not like I will do, you should explain her what are the risks and this should be the next action, and if she allows, you go away with that. Each time a clinical assessment is made, record the plan based on the shared decision. So this is the example. You assist that pain relief is required, so you offer companionship and relaxation techniques. You thought that normal progress is going on, so continuation of routine monitoring, and if pain relief is required, again offer whatever is available at your end. Okay, so this is the whole example of graph. This is how it is being plotted as I have told you. And after patient is 10 centimeter, suppose here at this time patient is 10 centimeter, now you will go to the section of second stage. So you start plotting in the second stage. You will plot fetal heart rate and fetal deceleration half hourly, and here again you will plot contractions, duration of contraction, and here P indicates when pushing begins. If patient has the urge to push, she is pushing, you just mention P. If not, then mention nothing. Okay, and descent is to complete when patient is full dilatation, so you are writing it at 0, you are marking it at 0. And again, if any oxytocin or any other fluid is being given, you just write it here. And again, share decision making as per your assessment and plan. So this is how you should be plotting LCG. This is how you should be interpreting LCG. If you face any problem in understanding anything, you can always ask me in the comment section. I'll be happy to answer you. And this is very important. You should be understanding this topic. Now, what are the disadvantages of LCG over partograph? It takes more time for interpretation, as there is no graphical representation like this. If it is like in partograph, it was crossing the alert line, action line, it was being shown like that, no? But here nothing is like that. You just have to write the letters and mark it with red, circle it with red. The space is limited to make comments in section 6 and 7. The presence of companion may not be acceptable to the medical staff, and there may not be adequate space in the labor room to accommodate both the companion and the patient. So thank you, and I hope I have been able to make you understand this topic. This is very important topic, and you should be knowing this. I have tried to include the theory part also. You can write these things in your theory if question comes. I have made this with so much effort, so I'll appreciate if you please like the video and subscribe my channel. Okay, thank you.